Well, good morning to everybody. Thank you for being here for what is one of our most special grand rounds of the year. Today, we are delighted to host our 2016 Donald E. Olson Memorial Visiting Professor. The D.E. Olson Lectureship, for those of you who don't know, was established by Dr. Olson's wife and his children as part of his legacy here at St. Vincent's, where he was the leader of the Department of Medicine for 41 years. Dr. Olson was a true patriarch in the internal medicine community here in Portland. He was Professor Emeritus of Pulmonary and Critical Care Medicine at OHSU and founder of the Oregon ACP chapter. His dedication to medical education, really at every level, was truly exemplary. And I just want to share some thoughts, a quote from physician colleagues of his who described, "Dr. Olson had this wonderful humility and sincerity and continuous quest for knowledge that immediately bonded him with his patients." And it's really in recognition of his great work that we have the opportunity to host each year a visiting professor. And I'm delighted this year to introduce Dr. Clarance Braddock. Dr. Braddock is board certified internist and also vice dean for education in the David Geffen School of Medicine at the University of California, Los Angeles. He previously served as director of the Stanford Center for Medical Education Research and Innovation, and is also chair of the board of directors of the American Board of Internal Medicine. He earned his medical degree at the University of Chicago, went on to do residency training with the U.S. Navy, and also received a master's in public health with a degree in healthcare ethics from University of Washington. Glad to have him back out to the Northwest today. Dr. Braddock was really specifically chosen for this lectureship because of his national leadership in medical education and specifically in the realms of bioethics and the doctor-patient communication. He's earned numerous teaching awards, has launched innovative educational programs across the nation, and was a founding member of the Academy for Professionalism in Healthcare. Dr. Braddock's research has focused on shared medical decision-making and patient-physician communication, and he's been actively involved in leadership in these realms, including serving on the Ethics, Professionalism, and Human Rights Committee for the American College of Physicians, and also chair of the Ethics Committee for the Society of General Internal Medicine. Obviously, I could go on and on, but let's get on with Dr. Braddock's talk. Thank you.
Yes, it is indeed great to be back in the Northwest. The weather's just as I remember it. It's a wonderful honor to be here for the Donald Olson Lectureship. From all that I've heard of Dr. Olson in terms of the kind of physician that he was and the values of practice that he embodied, that makes it even more of an honor.
Oh, it fell off. That's what happened. Can't have that.
I was up there freaking out a little bit.
All right, now we're ready. And I'll apologize at the outset. I'm on the tail end of a cold. I'm not infectious, but my voice may or may not hold up the entire time, but I've got my hot tea to try. So today I'm going to talk about shared decision-making and patient engagement, really because I believe that, particularly in the modern era, what's always been important is increasingly important. That is how we actually engage patients in their care. And again, I think very much in connection with the values of Dr. Olson. My specific objectives when we're done is that you're better able to define patient engagement and shared decision-making, to discuss the rationale for promoting these in clinical practice, why it's particularly important today, and then to leave you with some promising and practical approaches to promoting shared decision-making and patient engagement in practice. I'm going to divide the talk into three segments, sort of the what of shared decision-making and patient engagement, a little bit about the why, the rationale behind, and a good amount of, again, practical and promising approaches to doing this in practice. I hope that we'll have time at the end for your thoughts, reflections, questions, so let's go ahead. Let's start with the what. So first I want to talk about the broader concept of patient engagement, and then we'll hone in on shared decision-making. Patient engagement is a term that's been introduced into our vernacular relatively recently, in some ways a shift even beyond so-called patient-centered care. If you think of patient-centered care as moving from doing things to patients to doing things for patients, the shift to patient engagement is to move to even doing things with patients. This is a definition from one of the leaders in the patient engagement movement who describes it as a set of reciprocal tasks in which clinicians and patients work together to promote and support active patient and public involvement in health and healthcare and to strengthen their influence on healthcare decisions at both the individual and collective level. That's a pretty broad definition, and as this figure shows, patient engagement is really imagined to be across the whole spectrum of activities, not just direct care, but in terms of how organizations are run and policy making. So for example, many organizations that have shifted from us providing health care to or even for patients to getting patients involved in patient advisory councils. We're seeing more involvement of patients at the policy level. So for example, you think about PCORI and how patient-centered outcomes research has really tried to bring patients to the table to design research and to actually decide what are the right outcomes. For our purposes, we're going to focus on direct care and the notion of moving from providing patients with information and even beyond merely asking about their preferences to really trying to make decisions with patients. Now, the shared decision-making, the term itself actually comes from a President's Commission report in the early 80s. The President's Commissions, there were a number of them in the late 70s. This one had to do with informed consent. And the idea, this was really at the origins of the bioethics movement. Bioethicists, lawyers, others came together to try to put some meat on the bones of informed consent, which had largely been a legal term, right? A legal term that arose out of the courts. And so the President's Commission said this. They said the ethical foundation of informed consent can be traced to the promotion of two values, personal well-being and self-determination. And that ethically valid consent should be thought of as a process, not just a piece of paper, but a process of shared decision-making based upon mutual respect and participation, not a ritual to be equated with reciting the contents of a form that details a risk of a particular treatment. This, when I first read this when I was a fellow, it really connected with me because my first experience with informed consent was as a third-year medical student rotating on surgery. It's the first day of surgery rotation. I'm there with all the other students and house staff, scared to death of what's going to come next. And the resident says to me, "Braddock, go get Mr. Jones consented for a cholecystectomy." So what did I do? I took off down the hall. I had no idea what I was supposed to do, but I knew I was supposed to get consent. I came back with the consent, but I still didn't know what I was doing. So this notion of actually trying to rethink this, instead of getting consent, of actually engaging in shared decision-making, for me really started with that early experience. So the components of shared decision-making, there are various lists, but this is sort of the key elements of it. The idea of exploring the patient's role in decision-making, discussing many aspects of the decision, the nature, the alternatives, the pros and cons, relevant uncertainties, the impact on the context of the patient's life, making sure the patient has understanding of the choices, seeing if they want to get input from others, family, maybe their primary care physician, and then ultimately eliciting the patient's preference. Some have sought to condense these into a more parsimonious model, if you will, and this is one that's gained some popularity, so-called ask, tell, ask. This comes from a paper that took this ask, tell, ask framework and applied it to prostate cancer screening discussions. So the ask is to explore the patient's baseline knowledge, see what their level of involvement that's desired. So here they're asking the person, what do you know about prostate cancer screening? Some patients like to hear everything before making a decision, so that kind of thing. The tell is sort of the information. What is the PSA? What are some of the uncertainties? Trying to sort of provide the information so the person can make an informed decision. And the final ask is clarifying their values and ultimately seeing what their preferences might be. So ask, tell, ask is another model. For the purpose of today, I'm going to frame it in this way, that high-quality shared decision-making really has three pillars. One is the notion of the activated patient. I'll have more to say about that a little bit later. The next is about the nature of making sure the patient has adequate information, not all the information, but just adequate enough to be informed and ready to participate. And finally, for us to be prepared to engage in a patient-centered way. So more about that in a little bit. So let's sort of move to the why. I'm going to talk about the ethical foundation, some of the empirical evidence that supports why shared decision-making has become such an important practice, and then the most recent development, which has been understanding the impact of shared decision-making and patient engagement from a health policy perspective. So bonus points to anyone that can name all three of these historic figures. Bach, that's Immanuel Kant, Jeremy Bentham, and Jack Wenberg. So why do I have those three people up there? So Immanuel Kant we'll come back to in a second, ethical foundations, empirical evidence, and the policy rationale. So let's start with ethical foundations. So Immanuel Kant, for those of you who might remember, that name may be ringing a bell from your undergrad philosophy course. Something about the categorical imperative or something. So essentially he was, as a philosopher, sort of the founder of the so-called deontology movement. The notion that when we're trying to decide what's the right thing to do, we should look to certain sort of foundational ethical principles. So this is around the notion that shared decision-making at its core, we should promote it because it's the right thing to do. It's the right thing to promote patient engagement in decision-making. And again, this is the nidus behind the President's Commission recommendation, is that shared decision-making should exist. We should promote it. We should engage in it because it's the right thing to do. Others have incorporated shared decision-making in other kinds of sets of principles that guide clinical practice. So the patient-centered care framework that began really in the late 90s and through 2000s included finding common ground among these 6 precepts of patient-centered care. And really finding common ground was this notion of engaging the patient and finding the right path forward. For us, bringing to the table our knowledge, expertise, and clinical judgment, and for the patient bringing forth their values and preferences for what seems to be right for them. Similarly, when the quality movement began with a landmark report, Crossing the Quality Chasm, one of the things that the IOM emphasized as part of good quality was not just technically competent care, but also good communication, shared decision-making, and cultural sensitivity. So this notion of shared decision-making as being key to patient-centered care, being key to thinking about quality, really gets into this realm of understanding shared decision-making as the right thing to do. So why Jeremy Bentham here? So Jeremy Bentham is considered in philosophy one of the founders of utilitarianism, right? So utilitarianism, right? I know I'm stimulating some dormant brain cells here, but the notion that the right thing to do is judged by the consequences. If the consequences from a course of action are good, then that action is good. And in large part, this is the area in which empirical evidence around the impact of shared decision-making on clinical and other outcomes becomes very relevant. So first I'll start with research on what patients prefer. And there's been a large body of research over the past couple of decades showing that mostly patients do want to be engaged in decision-making. I say mostly because it's not 100%. One of the more recent studies found that depending on whether you compare shared decision-making to completely autonomous or to completely doctor-centered, sorry for the paternalism, it's a term that still lingers, but the notion is that about 3/4 to 2/3 of patients preferred shared decision-making to a more extreme model in either direction. Wendy Levinson, another person who ventured through the Northwest during her career, found that 96% of patients, almost all, would like some information and some choices, even though many would like to defer to the clinician's judgment in terms of the final decision. And I think it's important to reconcile this. Not all patients want to be engaged in decision-making, but we should approach each encounter, each patient, assuming that they do, but also being open to the fact that where they want to be on that spectrum will be a very individual choice. And I'll have more to say on that in a few minutes. And this has been a pretty enduring finding. Even going back to the late 90s, we find that, again, 2/3 to 3/4 of patients would prefer shared decision-making over a more physician-centered approach. We've also found that over the last couple of decades, a lot of evidence showing that shared decision-making can actually promote good clinical outcomes. And I'll just give you a few smatterings of that. In shared decision-making in the setting of asthma care, improves adherence to asthma medications. We see improved outcomes in depression, and largely through improved adherence, increased knowledge in patients with ischemic heart disease, improved patient satisfaction with mental disorders. And this data goes back really more than 30 years in terms of finding clinical outcomes improve when patients are engaged in shared decision-making. Now, parenthetically, and you can reflect on your own experience, largely this comes through patients having a better understanding of the regimen that we're suggesting, and with that better understanding, being more likely to adhere and more likely to take control and ownership, whether it's through adherence to medication regimen or adherence to checking their finger stick with their diabetes or whatever it might be. We can talk more about that in the Q&A. Now, one area where there's been a ton of research in the past 15 years has been in so-called decision aids. How many folks here have some familiarity with decision aids? So, a fair number. Okay. So again, decision aids in short are patient-based tools that are designed to support patients' engagement in decision-making. They typically include evidence-based information, some balanced value-neutral presentations of advantages and disadvantages, and some kind of tool that helps the patient to clarify their own values and preferences. This chart shows the result of several systematic reviews by the Cochrane collaboration. As you know, the Cochrane collaboration does systematic reviews across a wide range of healthcare interventions. This was looking at randomized controlled trials of decision aids in practice. And what you see is, from 1999 to the last one that they published in 2014, there now are 115 randomized controlled trials of decision aids showing a positive impact on healthcare outcomes. 115. The folks I know at the Cochrane collaboration like to say, with a little bit of irony in their voice, that if you had a new medication that came on the market with 114 clinical trials showing evidence, it would be a blockbuster. So in these clinical trials, they've shown things like improved knowledge, more accurate risk perception, a better match of values and choices, reduced decisional conflict, helping people to go from undecided to decided, making patients less passive, improving communication, and some potential to reduce overuse. This has been, again, will give a foreshadowing of the health policy rationale. So a large body of data supporting, providing evidence that shared decision-making can enhance outcomes. Which leads me to Jack Wenberg, the policy rationale. He's not a philosopher, he's a health economist. Many of you have probably heard of his work. Really was a founder of the so-called Dartmouth Atlas. The Dartmouth Atlas began as research exploring Medicare claims data and finding significant and often huge variation geographically in the utilization of certain practices. So for example, cesarean section rates, huge variation geographically. Rates of back surgery for patients with back pain, huge variation geographically. I think we can all relate in our own experience. When you've worked with colleagues, you have maybe two surgical colleagues, one who trained in a program that's more conservative, quote unquote, with regard to when to operate, when to do a laminectomy. Another from a program that maybe had a higher rate. The place where we train, the philosophy, the approach can be rather different. And so Wenberg wanted to understand that from a policy perspective and see ways that the funding or framing of healthcare delivery could be altered to try to reduce the undesirable variation. There's always going to be some variation, but the idea was to target the undesirable variation and try to reduce or eliminate it. So in this model, there were really sort of three main contributors to this variation. One was the notion of effective care. Certainly some of the variation might be that some physicians were not keeping up with the guidelines and sort of emerging evidence, and so certainly you would want to make sure that there's appropriateness from an evidence-based standpoint. Sometimes the variation is so-called supply sensitive. Probably the best example of this is if you look at communities that start to add imaging. If you have, you think back to the days where MRIs were hard to find. If you go to a community that had one place that did MRIs, you put in a second MRI unit or a third, you see dramatic increases in utilization. Sometimes the supply of a service actually drives its utilization. The third category was what Wenberg called preference-sensitive care. And this is really the notion that at the margin, certain kinds of interventions, certain kinds of services were driven largely by the style of the physician, his or her preferences, but also could be driven by in that case, by the preferences of the patient. That if you had shared decision-making between doctor and patient around the pros and cons from an evidence-based standpoint, you actually could close the gap of variation that was driven by this preference-sensitive care. This is a pretty important observation and has driven a large body of research to that point. One example of this is this paper from a couple of years ago from Group Health. So Group Health, like many sort of closed system practices, is seeking to try to derive value in practice and employ decision aids throughout its practice, and in this study, studied it with regard to hip and knee surgery. Again, hip and knee surgery are a great example where there's no real objective measure of when someone should get a hip replacement or a knee replacement. It's largely driven by the patient's experience of pain, dysfunction, and the surgeon's sort of, if you will, threshold for doing the operation. So it clearly fits in the wheelhouse of preference-sensitive care. So they basically, for every patient in Group Health that was going to be referred for hip and knee replacement, they did the following. They sent that patient a decision aid, a booklet which gave this sort of information, pros and cons, value-neutral presentation of pros and cons, and a DVD which had patient testimonials on both sides, and then did that before they went to see the surgeon. And what they wanted to see the degree to which it influenced the rates of surgery and, importantly, the costs. So what they found is that compared to the control group that did not get the shared decision-making intervention, there's about a 26% reduction in hip surgery rates and a 38% reduction in knee surgery rates. And this is after 180 days from the referral. They went out 6 months and looked at total cost, trying to take into account not just the decision about surgery, but the overall cost, and found pretty significant reductions in cost. This has also been replicated in a health system, and this is David Wenberg, Jack Wenberg's son, who did a study in a large health plan, 170,000 patients, and they did a randomized controlled trial of usual care versus shared decision-making. The shared decision-making arm got decision aids sent out to them by mail. They got coaching. A coach would call them on the phone around self-care, around behavior change to try to promote some of the alternatives to interventions. And what they found was that the shared decision-making led to reduced costs of $8 total, about $2 per member per month. Now you think $8 isn't very much. Well, you just do the math, $8 times 170,000 patients. This health plan found a huge value. Again, it's not just about saving money, but if you're a health plan, you do want to save money. Largely what they found was that a lot of the savings had to do with reductions in inpatient stays, a little bit reduction in outpatient visits. Interestingly, pharmacy costs went up a tiny bit, not significantly, but again suggests that shared decision-making could shift some of the nature of practice in a way that may be valuable both for patients and for our health system. Now, this rationale got shared decision-making on the map in the health policy realm, so much so that shared decision-making was actually written into the Affordable Care Act. It's written into the Affordable Care Act in 2 provisions. This one provision talked about trying to promote decision aids and to set quality standards and to provide funding. So in fact, in Washington State, right now, Washington State is the first state to be moving forward to certifying decision aids, that is setting criteria for what qualify as good decision aids, and largely trying to do that to drive uptake of decision aids throughout clinical practice. Similarly, the other section is in the CMS Innovation Center, which has yet to launch this effort, by the way, but did have funding to promote the development of decision aids around the country. So these 2 provisions really are the result of this 15 to 20 years of work on trying to understand variation in care from a shared decision-making lens. Now we're seeing this pop up in other states. The green states are those in which shared decision-making mandates have been passed, largely saying that there should be shared decision-making and trying to set regulations in place. One example would be in some states this has led to malpractice provisions, saying, for example, that there's some malpractice protection afforded to physicians when in fact there's evidence that they've engaged in shared decision-making. So these kinds of things actually begin to move the needle on the uptake of shared decision-making. Now I'll confess that when I last looked, I know that there's pending legislation in Oregon. I don't know if anyone might know if there's anything more pending. But one of the interesting things in Oregon is that a few years ago, there was a study with the Oregon Rural Practice-Based Research Network looking at the impact of shared decision-making in rural practice. This is interesting because the idea was that to try to understand whether it could be implemented in a more distributed network of practices and in practices that weren't quite so concentrated as we see in urban centers. So these are the 6 sites. This was funded by a nonprofit foundation, the Informed Medical Decision Making Foundation, and implemented across the state of Oregon. I don't personally know these sites, but I put this up here because I thought maybe some people might recognize some of these clinics. Maybe you have colleagues there, maybe. But these are the 4 sites, and in each of the sites, they deployed decision aids and trained staff to function as decision coaches. What they found in this environment was they wanted to compare this with the other sites where some of these randomized trials have been done. And this is the question asked of patients: how important is it for your providers to give you decision aids? And you can see this is the extremely and very important, very significant positive response from patients in these rural practices, very similar to what we saw, what they saw in other areas. Similarly, the usefulness question was posed, and again, pretty comparable usefulness across a range of different kinds of decisions, from kind of primary care things, advanced directives, screening, etc. So this health policy dimension has been extremely interesting to follow because it represents this sort of push to try to use shared decision making as a way to enhance the value of care by aligning patient choices with appropriateness in a way that's more optimized. So the balance of time I'm going to spend on talking about how do we do this. If we believe it's the right thing to do, we believe that there's evidence that it can promote better outcomes. We believe it's an important part of the evolution of our healthcare system to try to provide value-based care. Then how do we do it? So again, I'm going to return to this model, the notion of the activated patient, the informed patient, and the patient-centered clinician, and walk you through what I hope will be a few, what I think are promising and ultimately are hopefully practical ideas. Let's start with the activated patient. So patient activation is another construct that's been in the literature over the past several years. And it's this notion that when patients come to the clinical encounter, even if we're ready to get them engaged in shared decision making, they may not be ready. They may not be accustomed to that role. They may not have thought about that role. And I think you can reflect in clinical practice the number of times that you begin to try to engage a patient and they say, well, whatever you say, doc, that kind of, and now sometimes the patient really isn't going to want to be engaged in shared decision making, but most of the time they do. So this notion of trying to help them to go from starting to take a role, to building confidence and knowledge, taking action and being able to maintain. This is part of the patient activation spectrum. So I'm going to tell you about a few kinds of ideas that have been shown in literature to have some benefit. This one is a patient activation in the waiting room intervention. So in this, the clinic has someone in the waiting room, typically a staff person, might be an MA, might be someone, but someone trained to sit with patients and go through about a 10-minute conversation in which they talk about decisions made in everyday life, what is a decision, and talk about how a simple act on their part of asking a few questions can help them get involved to figure out what their issue is for the day, help them brainstorm some questions to ask, decide if they want to ask open or close-ended, and ultimately what are the prioritize, what are the most important questions. So when they go into the visit, they actually have a handful, 2, 3, 4 questions that are relevant to their visit, but they've also been coached into a little bit more of an proactive stance in terms of asking those questions. Another model is the so-called ASK model, Ask, Share, Know. This one's a little bit more of a pared down version of that, and essentially, in this is actually a study from Australia. They had a short video where they taught patients to ask literally just 3 questions. The first is, what are my options? So if I say, well, your cholesterol's high, we need to start you on a statin, blah, blah, blah. You know, well, Dr. Braddock, what are my options? And then what are the possible benefits and harms of those options? Again, one of the options is always to watch and wait. And then how likely each of these to benefits and harms to happen to me? So these 3 questions, they did this with a a number of patients in the clinic. They showed them the short video. I think it was like 2 minutes. And they showed that patients were very quick to take up asking these questions. Again, suggesting that this is a very promising practice to try and help patients get ready for the visit. These kinds of patient activation interventions have shown to be quite effective, and again, helping patients literally to just have the confidence to develop and ask questions, but importantly, to increase their participatory behavior. So people have actually studied this where they videotape or audio tape visits of patients who have gone through these kind of interventions versus controls, and they find with behaviors such as asking questions, making expressions of concerns, or so-called assertive responses, that it increases quite significantly. Now, you might be thinking at this point about those occasional patients for whom asking questions is not a problem. The people who come in with the scroll of questions printed out from the internet. That's not what this is about, right? That's not what this is about. In fact, for those patients, this kind of intervention helps them to focus their questions to the 2 or 3 questions that are most important. So again, that's something maybe we can talk a little bit about in the Q&A. Another kind of patient activation approach is to actually explore the patient's desired role in decision making. I mentioned this earlier. And this is the so-called control preference scale. Again, in this intervention, the patient is shown this little card which has these different 5 different parts of a spectrum from I prefer this, to make all decisions about the treatment I receive. On the other extreme, I'd rather let my doctor make all the decisions, to something kind of in the middle. And patients are able to sort of give to us where they kind of fall on the spectrum. And this can be very helpful to the clinician to understand the person who may be more passive or would like a little bit of information to right-size shared decision-making to where they are. Another intervention is so-called decision coaching. I made reference to this a moment ago. And the idea is that it's a trained role in which someone augments the role of the clinician who's providing the clinical judgment and expertise, and the patient who's got their values and preferences. This person's job is to assess where the person is in terms of their decisional needs, how much information they have and might need, to provide the decision support that's appropriate to that, whether they might need a decision aid or just some coaching around question asking, and really to sort of help get the person ready to be an active participant in decision making. So decision coaching has been studied a lot, and it's been deployed in a lot of settings. This is a study from, again, a systematic review from 2012. And what you'll see here across the top is that largely these are not physicians. They're nurses, in some cases health educators, genetic counselors, the kinds of things they do: provide information, clarify values, build skills in communication, screening needs for implementation. So it's a widely studied, and it's largely been quite effective. It's a little bit labor intensive, and as you might imagine, but for some practices in some settings, it's proven to be quite valuable. So that's the activated patient, the notion that we use patient activation interventions, exploring patient's decision-making style, and decision coaching to activate the patient. Next, we need to have an informed patient. So I mentioned decision aids. Again, I won't say much more about it, except that there are very strong body of evidence around decision aids, whether they're booklets with DVDs, as you see here. There are some who have produced decision aids that are much more kind of low-tech. This is so-called option grid. This one's for PSA testing. It literally goes through some commonly asked questions and talks about, gives a brief bullet on having a PSA versus not having a PSA. There are a variety of web-based tools. This one's from the Agency for Healthcare Research and Quality. This is on osteoporosis. And it walks the person through a series of questions. So they come in a wide variety of shapes and sizes, and have become a very, very important tool. Ultimately, they should provide information, as I said, facts, probabilities. They should help clarify values, and they should provide support for patients in aligning their values and preferences with the decision that probably is right for them. And that 115 randomized trials, these are all the decision aids that are available. You can see a lot in medication and screening, more and more in surgery, and in obstetrics has been a very big area of growth. So again, The Cochrane Review has a lot of these listed, and many of them are available on the internet. As an adjunct to that, there's been work in really trying to look at how we communicate risk and probabilities to patients. A couple of papers that some colleagues and I, and this one in particular, we looked at different, we tried to draw from the risk communication literature to understand how to help people understand probabilities. And it's just one example of the ways in which, if we really want to have people become informed, we have to really provide information that's digestible. So for example, if you tell someone there's a 60% chance if you have a mammogram that you might have a false positive, like what does that really mean? So people in the risk communication world have found that they use these little stick figures. This says that follow-up testing is common. If you had 1,000 women who had annual screening mammogram, that 600 of them will need a follow-up. And I don't know the science behind this, but this is much more understandable to the average layperson than 60% or 6 out of 10 or any other numeric way. And this goes on to say, out of those 600, 200 will need a biopsy. These kinds of ways of presenting probabilities can be quite helpful. So more and more decision aids are trying to fold in these approaches to making the information more digestible. So again, we have the activated patient, now we have the informed patient using evidence-based decision aids, being attuned to literacy, and health numeracy, and trying to use appropriate risk communication strategies to help the activated patient have the adequate information. Finally, we want to have the patient-centered clinician. That's all of us. My own work in this area shows that despite our best efforts, we're not always doing a great job of involving patients in decision-making. So this is a study that we did in the late 90s, 3,400 medical decisions across 1,100 primary care visits. We audio taped all of them and then had blinded reviewers analyze those audio tapes to see how much shared decision-making was occurring across a range of decisions, very basic ones, more intermediate ones like new medications and surgery. And what we found is that the rates of shared decision-making were quite low. Overall, only 9% of these visits, of these 1,100 visits, had adequate shared decision-making. So that has been part of the larger conversation. Think about how can we get better at the kinds of communication behaviors that help invite and engage patients in decision-making. So there's a lot of resources available to support that effort. I know that these are parts of the training programs across the country and here. This is a wonderful tool from the American Academy of Communication and Healthcare called DocCom, and it includes a video, basically like a video textbook of patient-physician communication. It's a wonderful tool. That same association sponsors workshops. They can do train-the-trainer. A lot of institutions around the country are bringing in groups like this to train their physicians on better communication techniques to really, in the area of shared decision-making, to really draw patients in and give us the tools so we can be more effective at that. One of the things that I've worked on with colleagues is trying to sort of develop time-efficient prompts and scripts to sort of routinize this, because we all recognize that shared decision-making, as I describe it, might be making you think, well, that's going to take a lot of time, but to sort of try to be more time-efficient and still be able to do this. So these are some of the things that have emerged from this work, and largely it's talking with clinicians around the kinds of things that are best practice among clinicians who do this very well. I'd like us to decide this together as a way of framing the nature of the relationship. How do you like to make decisions? I've covered a lot. Just to make sure I was clear enough, tell me what you heard me say. Again, trying to promote finding out how much the patient understands. Some people like to go with treatment A, others like to go with treatment B. Which way are you leaning? Again, a time-efficient way to elicit preferences. This might feel like a big decision. Who else would you like to help you make that decision? Again, this came from a specialist who wanted to make sure the patient might have the opportunity to check in with their primary care doctor. There are also a lot of decision support tools that health systems have tried to put in place to help clinicians to be time efficient yet promoting shared decision making. Palo Alto Medical Foundation, part of the Sutter system, developed shared decision making navigators. These were individuals, they weren't exactly health coaches, but they were trying to help the clinicians guide patients to resources, including a library of decision aids that they put together. This model was really interesting. So this was a breast cancer center at UCSF. And what they did is When they got the referral, before the woman came to the referral, usually it was after a biopsy result, she would receive a decision aid and a phone call from a decision coach. Did you get the decision aid? Have you looked at it yet? What questions do you have? And they'd go through that process, maybe a follow-up phone call. So when she came for the first visit to see the oncologist, she had already been teed up with the information about what might be the choices that they would discuss that day, and that it was found to be phenomenally valuable for both the patients and the physicians. Several places, as I've mentioned, Group Health, but also Mass General, a lot of places around the country, have actually embedded decision aids in the electronic health record. So when I make a referral in such systems to or an orthopedic surgeon for someone with who might be a candidate for a knee replacement, I can actually also attach to that an order for a decision aid, and it gets mailed to the patient. So again, before they see the specialist, they've had an opportunity to engage into at least into learning more about their condition to help sort of streamline that visit. So the activated patient, through decision coaching, exploring their decision-making style, patient activation interventions, informed patient being attuned to health literacy and numeracy, using evidence-based decision aids and appropriate risk communication strategies, patient-centered clinician, time-efficient models, investing in training around better communication and feedback, and using decision support tools can contribute to high-quality shared decision-making. So hopefully in this talk I've been able to provide you a better rationale for both defining and a better rationale for shared decision-making, and share with you some of the promising and I believe very practical approaches to bringing this into clinical practice more extensively. And again, I think that shared decision-making is so important, not just because of the health policy rationale of the evidence, but because at the end of the day, we want to value the individual experiences of patients and honor the traditions of medicine and practice by really being attuned to those, even as we're bringing forth our good clinical judgment and experience, being open to and listening to the values and preferences of patients and meeting them where they are. So I thank you so much for the wonderful invitation to come here and invite your questions. Thank you. And my voice held out. Yay. Please.
I have a question about the difference between the 2/3 that were interested in shared decision-making
Yeah.
and 1/3 that were not. Are there any studies in relation to the level of education
Yeah.
or the level of
Sure.
finance, poverty
Yeah.
or not? How does that fit into this?
Yeah, great question. So the question was, what do we know about the patients who prefer or don't prefer in terms of education or socioeconomic, et cetera? And certainly when people have studied that, the following tendencies come out. Younger patients are much more likely to want to be involved than older patients. And some of that might be generational differences and maybe many other reasons, but that's been one finding. Another finding is that patients that are more well-educated, patients who have college education or beyond, much more likely to want to be involved in decision-making than those who have maybe don't have college education. Patients from lower socioeconomic classes, much less likely to come in and say they want to be engaged, and from underrepresented minority groups also. Inside that, I think, are some of the power dynamics that exist within, that we know exist within the doctor-patient relationship. And I certainly have found over my time that patients who maybe come from a lower socioeconomic status or don't have education are much more intimidated by physicians than others. And so even in that group that starts off saying, and I remember this for the years I practiced in the VA, literally when I'd go into and start talking to a veteran about his, usually it was his medical treatment, they would say, whatever you say, doc. No, it's important for me to hear your thoughts on it. And they'd kind of give me this look like they didn't really believe that I wanted to hear what they had to say. So I think even within that group, with some coaching and some kind of openness, many of them will actually embrace it. We all know these kinds of stories from our own experience as well. So that veteran goes to see me in the office and says, "Oh, whatever you say, doc," and I give them a prescription. They go home and their spouse said, "So, what did Dr. Braddock say today?" He gave me this medication. Well, what is it for? I don't remember. So, I think that we recognize that their passivity may actually be intimidation or a learned behavior that in some ways actually can still be problematic. But that's a longer answer. But yeah, there are some certain trends like that do.
And do the things that you suggested to improve the patient's involvement work with that group of patients?
Yeah, largely they do. Yeah, what you find is even patients who come into it with a level of more passivity, with those coaching or patient activation interventions, will ask questions. That 3 questions thing started in Australia because they found out that so many of their patients literally weren't asking any questions, and so they wanted to make something very simple. And the fact that people were asking these 3 questions, they felt it was something they could do, didn't feel too challenging, and it really does have an impact. Yeah, I saw a question, but please.
I couldn't help but notice the folks about whom you were speaking seem pretty decisionally intact. Is there a lot of work going on for those who are not so decisionally intact, like brain injury
Yeah.
or mental illness?
Yeah, well, I think a full treatment of that obviously would be a topic for a whole nother discussion, but I'd say the short answer would be that for patients who lack decision-making capacity, largely our efforts, and again, I'm telling you stuff you already know, is to determine whether or not it's appropriate for them alone to be the decision maker, whether they might need some additional support from surrogates of one sort or another. In the instance of someone who isn't quite to that point, where you believe they still have the capacity to make their own decisions, but they may have some impairments, it certainly is a challenge. Ultimately, and again, I'm putting on my hat as a bioethicist, when I would do ethics consults in that setting, I think largely my advice would be that if the person is unable, maybe they may be unwilling, but if they're unable to actually participate in a meaningful way, even if their cognitive functions in other sense seem reasonably stable, they really should have someone helping them. Again, whether it's a formal designation of a surrogate or merely the involvement of trusted others, family, friends, primary care physician. So I think that the same principles apply, but a much more nuanced approach would be necessary. So I'll hand back there. Yeah, please. Mm-hmm.
Do you know anybody who is doing something creative? Like I imagine having your office visit, and we expect a decision by the end of the visit.
Mm-hmm.
Or at least, we write up the plan.
Yeah.
What the decision is. You don't want to make people come back
Yeah.
a million times. Do you have people doing sort of the outreach, saying, I'm just calling to see what you thought about your meeting with the doctor?
Yeah. Yeah, I'd say, that's a good question. I'd say that what I'm seeing are really 2 different kinds of strategies. One in the specialty setting, one in the primary care. The specialty setting, what's people are finding is that to try to anticipate the decision before the visit, and this is like the orthopedic example, at the time of referral. So someone referred to an orthopedic surgeon or a vascular surgeon or a cardiologist or whatever, is to provide them with the decision aid, so when they land in the visit, that the physician has confidence they have some certain amount of information that makes it more likely they're going to be able to make a decision at that visit. Primary care is a little bit more tricky because the nature, even though we talk about the annual prevention visit, so many, and I don't know what the practice patterns are here, but many primary care physicians kind of interdigitate the prevention with everything else that you're seeing, particularly people with chronic conditions for. So you never really know in any particular visit what the decisions might be. But in the setting where in large health systems that do a lot of prevention, they've tried to segment out and sort of basically provide people with decision support for the prevention visit around mammography, PSA, colorectal cancer, so they can come in prepared to make a decision. I would say that the most difficult one where I haven't seen a really good sort of idealized product is the more typical primary care visit, at least in my experience, where you never know what decisions are going to come up. The way in which I recommend to people to handle that is to try to use, as a clinician, some time-efficient practices that have been honed from your own experience, from those of colleagues, to try to tee up the common things that come up that aren't really super high stakes. Their lipids are high, and they've tried lifestyle, and maybe want to start a statin, so you can do some of that. when you believe that it's more high stakes, or you have explored a patient's decision-making style, and they see them, they want to be a little bit more engaged, to say, well, let's decide to do this. Here's some information that you might look at online or whatever. And yeah, maybe be able to do that follow-up by a phone call, or if you have e-messaging, to be able to do that. It goes back to the old days where you give somebody a prescription and say, if you're not better, you can go ahead and fill this kind of thing. But I think that's not really been worked out well, and I think that's probably the more challenging area. Yeah, please.
So what kind of involvement have you had with pharmacists then in this kind of thing? And secondly, how about caregivers as opposed to the patients themselves? I have a lot of people who don't understand.
Yeah. Well, I think that you mentioned pharmacists. I think there's in these models and sort of in the medical home, I think in some ways shared decision making opens up a lot of ways in which other members of the healthcare team can be very, very valuable. The pharmacist, the nurse, the health coach, and so I think that's a vital importance. And similarly to the other question, caregivers, we know that higher percentage of visits, I don't remember what the last study was, but it used to be that most visits there was a patient by themselves, and now the majority in many settings of visits, particularly in primary care, the patient comes with someone else, a caregiver, spouse, partner, friend, some other kind of trusted other, and those people can be vitally important in helping to support the empowerment of the patient engagement, and so I think they're very important. Yeah, please.
First of all, thank you. I would say there's another element to this, especially in patients with complex illnesses, and that's the fear on the part of some patients that if they disagree with what they think the doctor wants, somehow it will damage their relationship. And I think it's very important, and I know it's something I do personally, to tell a patient very explicitly that this decision really is yours, and it has no bearing on the quality of our relationship. It is not my way or the highway. And that if you choose to do something other than what would be my first recommendation, it has no impact on our relationship. And I really think that should be explicitly expressed.
No, I think that's vitally important. And I wish I could tell you that the opposite rarely or never happens, but I think we know of instances, I'm sure you can think of, where you've seen that happen. And I think this is where we as a profession need to train our colleagues who are up and coming, and sometimes our colleagues that are our peers, that's such a vitally important value. At the end of the day, what we're bringing to the table is our clinical best judgment in making a recommendation. And sometimes, as long as a person has a clear head and a set of facts that are valid, it is their decision. I think largely this issue of patients being hesitant to be engaged, sometimes there is that fear that if I disagree with the doctor, he or she's going to be disappointed or maybe even angry with me. And I think anything that we can do to disavow that is vitally valuable. Please.
Just kind of piggybacking on that comment, I would like to know or hear from an ethicist like yourself whether there's been some writing about the conflict of the primary care physician who has a little cute graph from the health plan showing what % of my patients are getting statins for high risk. When I use the Mayo shared decision metric, which I do in the room with my patient, even at 15%, which is considered high risk, you got to treat a lot of people before you prevent one heart attack.
Fair point.
Same with mammography. I have a little poster on my door showing residents how bad mammography really is, and yet I get a cute little graph from the health plan saying what % of my patients have gotten a mammogram. I actually wind up talking a lot of people out of mammography. When I share the decision with
Well, as you start to look, I mean, it's a great question. And as you start looking at data, we realize in an evidence-based world, the number needed to treat is a kind of a compelling number in two ways. It's like, are you going to be the person that's going to benefit? I actually completely agree with you. I think that this is probably the next frontier on this health policy journey, and I don't know how this is going to play out. Shared decision-making largely got on the map, rightly or wrongly, because it's been perceived as a way to derive more value, to eliminate unnecessary. But it also could be a way to refine what we're actually asking, particularly primary care physicians, to do. So what we'd ask primary physicians to do is to have the conversation and reach a shared decision about intervention X, rather than to just do intervention X. So in an imagined, idealized world, if you're having that kind of, that sounds wonderful, by the way. Just I think I couldn't have described a better practice. If that's what you're doing with all of your patients, then you should be at 100%, regardless of how many actually get a statin or actually get a mammogram, right? I mean, that's I think what you're saying, which I largely agree with. It's not clearly not there yet, but I think this is where I think for me the role of again getting a little bit off the topic, but why it's been so valuable in shared decision making to have people advocating in the policy realm, because health systems and payers are largely driven by the economics. It is what it is. But I think we as a profession can help to educate and advocate for those kinds of change. I would think that would be the way to go. Sorry we're not there yet, but I do agree with you. Please.
Your spectrum was very interesting in that there's the far end of wanting a lot of control
Yeah.
and the far end of, and I think most of us would agree that it's probably not ideal for the patient and not ideal for the doctor to be in the doctor whatever you think
Yeah.
category. But is it also not optimal? Do patients that end up getting overdiagnosed,
Yeah.
overtested, overtreated in the far end group, is there a sweet spot in that spectrum that we should be shooting?
Yeah. Well, the answer is yes, yes, and yes. I mean, you can all think of examples, and probably the example that I see that's the most stark is the so-called VIP patient. And you might imagine at UCLA we get our fair share of those. And the VIP patient, and again, it may just be you think about your own healthcare. Sometimes if people know that you're a physician, and then people begin to shortcut their own good judgment and may overtest, may err. And there certainly is a large amount of evidence of the harms that can come from that. So I think the sweet spot is really shared decision making, or at least to be able to not have complete abdication by a patient, and certainly not having complete control by the patient. Now, this is an important dynamic because as you look into sort of the lay press around patient engagement, there is a contingent where really people are seeking real control of their health care, and a lot of the newer trends, the sort of the virtual physician visit and other things are people who really want to be able to control their interactions with the healthcare system. And on the one hand, it's a demographic trend in terms of people being, look at this. You want to book an airline, you just go online, you just book it. You want to book, you go to StubHub, you get people want to have that kind of control of their health care. It's a good thing, but it also has potential for harm if there's too much application on our part of that dyadic. So I think that's important. Please.
Was there simultaneously a study on the rate of malpractice by having shared decision making?
Very good question. So the short answer has been actually a number of interesting studies over the past 15, 20 years, including one by Wendy Levinson, where they looked at actually using similar audio tape methods. Physicians who did good shared decision making, they actually had they worked with a malpractice coverer. I think it was I can't remember which one. But it covers Colorado, Washington, Oregon. There's some company, maybe you know who they are. At any rate, what they found is that those physicians who had better communication behaviors had a lower risk of malpractice claims. So it's not necessarily just shared decision making, but it's more of the broader range of communication behaviors. Interestingly, another study, this was fascinating. The researcher took audio tapes from primary care visits, and she had a method to garble the audio so you couldn't tell what they were actually saying, only the tone of voice. And they had blinded reviewers listening to the tone of voice. For the tone of voice was versus so more of a collaborative versus more of a bossy, right? And what they found was a very strong correlation between malpractice claims and the bossy kind of directive voice, much lower risk for the more collaborative, engaging voice. Again, they had no idea what the content was. So I think most definitely, and that's actually been folded into some of this legislation, that shared decision making. Again, several states have baked this into their legislative approaches to actually provide malpractice, not complete relief, but significant malpractice relief for physicians engaged in shared decision making.
What about relating quality of results to malpractice?
Well, in fact, that's what's been baked in. So let's say, for example,
the patient has a good impression, that's one thing.
Yeah.
And they have a good impression of the doctor.
Well, in the legislative efforts, what the notion has been is that if someone has harm as a result of a procedure or intervention, and there's been shared decision-making, then there's a cap on the malpractice exposure. The notion being that if we've made a decision together and it turns out there's a harm, then we're in it together. And that's largely been sort of the mechanism of action whereby if people are engaged in shared decision-making, feel strong connection to the doctor, feel like that it's our decision, not your decision, then they're largely less likely to sue. But if they do sue, the idea is that, well, you did your best to kind of engage them in the process, and so you shouldn't be as liable at the same level as if you didn't do shared decision-making. How are we doing for time?
We're at 9 o'clock, so for any people who need to leave, please feel free. We can take more questions
Yeah,
down front.
happy to take more questions down front. Thank you.